right, let's get started. Hi, everyone. I'm Cameron Foster. I'm the Programs Coordinator for Millions of Conversations. Welcome to our fourth Conversationalist Series event of 2021, Healthcare in Our Communities. I'd like to begin by introducing our partners at Core 54, a Tennessee coalition that brings women together to educate, engage, and empower on issues that matter. Core 54 unites and amplifies the voices of its members to create positive change, and in 2021 are focusing on policies related to education and healthcare. Many thanks to our partners at Core 54 for helping us come together for this timely and important conversation. And for those of you not yet familiar with us, Millions of Conversations is a national organization headquartered in Nashville, Tennessee. Our mission is to bring people together by uniting Americans through common values for a shared future. This event is also part of the National Week of Conversation, an effort led by the Listen First Coalition, which provides opportunities for Americans to have conversations and forge connections despite differences. Today's event will center around access to and equity in healthcare and wellness. Good health and wellness are valued universally, but our healthcare needs and the level of access that we have to address them varies based on who we are, where we are, and what type of community we live in. The panel discussion today will bring together two experienced professionals in the field to share insights they've gleaned through examining this issue firsthand, albeit from different perspectives. Following their conversation, our attendees will have the chance to discuss and share themselves during a breakout session. We'll reconvene at the end of the event to wrap up and reflect on what we learned and how we can continue to have powerful and productive conversations. Additionally, feel free to drop any questions or comments you might have in the chat box at any time during today's event. And with that, let's jump right in with our panelists, Dr. Ted Fischer and Dr. Cherae Farmer-Dixon, who will introduce themselves, their work, and how they define health and wellness.
Cherae, you want to go first?
Okay, I'll do that. Good evening, everyone. I am the Dean of the School of Dentistry at Meharry Medical College. I am a dentist by profession. My passion is public health, so I term myself as a public health dentist. And when I think about public health and dentistry and health in general, I think I define health as mind, body, and soul. There's that saying that what goes into your mouth affects the rest of your body. And so that is very important to me, that you not only take care of your physical health, but you take care of your oral health, you take care of your mental health, so that you have a comprehensive and full wellness of yourselves and taking time out for yourself. Again, another saying is you can't be good for anyone else if you're not at your best self. And so being your best self to me means that you are going to make certain that you are physically healthy. That means regular doctor visits, exercise, diet, eating healthy. You're going to be mindful of your oral health and getting routine exams, and then taking time out for your mental health as well, to make certain that you are mentally fit.
Wow, I don't have much to add to that definition, which is great. So I'm Ted Fischer. I'm a professor of anthropology at Vanderbilt University. So a little different, not in medicine as my colleague is, but I look at the cultural context of health in different places around the world. So I come at it from that angle. And I would just underline what Cherae has said about what health is. I think it's really important to think of health not as just the absence of illness, although we do think about it that way a lot of time. And I think we use our healthcare system that way a lot of time. And I think our healthcare system is set up to treat illnesses, right? And acute problems that present in the clinic or in the hospital or wherever it may be. And the whole economics behind that, a fee for service kind of thing, makes us look at one little aspect rather than looking at the whole picture, which you were pointing for us to do. And in that sense, I think it's also nice the way the question was set up. What do health and wellness mean? I generally use the term well-being, but it's getting at the same thing as wellness is. And I think it's really useful here, again, for the reasons that you already pointed out, is that it points us toward a more holistic, a more integrated understanding of health. And in fact, I would argue that improving well-being, it should probably be the measure of societal and political success, at least as much as GDP is, or just increasing our economic productivity at any cost. And some countries have moved in that direction in trying to come up with more holistic measures. So again, I think that we need to look at health holistically. That well-being is a nice way of capturing that. And in this, I would just again to underline what Cherae has already said, that in this, health isn't just about medicine and biology. As important as those are, and we need the lab scientists coming up with drugs, and we need the clinicians, and the dentists and the surgeons and everybody else. At the same time, it's all part of a bigger system, and public planning and transportation, and how that affects how much we move around. Food deserts and food swamps, and environmental exposures and trust. All these other things, it's all part of the system that produces health one way or another. So that's all just an elaborate way of agreeing with you, Cherae. So what do you think
Absolutely.
the biggest...
I think when we think about
Well, were you going to say so? What were you about to say?
No, go ahead.
No, I was through. I was actually
You're gonna ask a
trying to
question?
hand the baton over to you, but I was a little clumsy about it.
Well, I was getting ready to talk. I was actually getting ready to, say, let's talk a little bit about healthcare and health equity, and that brings us to what are some of the biggest challenges in healthcare equity in the United States.
They have a phone number and a contact.
What do you think some of the biggest challenges are?
Yeah, I think some of the biggest challenges are social and political and economic, and not just medical per se. We know how to, we have the capacity to provide high quality medical care in this country. Now, not to everybody, but we have the capacity, we have the know-how to do this. But where we're falling down, I think, is often in access and accessibility. So I really think our biggest challenge is the debate around values, and this is something that I know Millions of Conversations has been working on. It's really a debate about values, freedom versus solidarity, or whatever it may be, as much as any technical problem with the system today.
And I was wondering if I could jump in, actually, Professor Fischer, if that's okay. Yeah, thank you. I was gonna ask, actually, if you could, sorry, Cherae, I don't know if you wanted to go ahead, and then I'll ask my question.
No, go ahead. It'll all gel together.
Okay. Okay, great. Well, I actually wanted to just ask if you could expand a little bit on the research that you did with the Robert Wood Johnson Foundation around values, and what you gleaned from that research, exactly how it related to the global context, but what the lessons learned that you also see in our own backyard here in Tennessee, specifically and particularly around that values-based piece.
Absolutely. In terms of the pandemic, and I know that we're talking about healthcare broader than the pandemic, but we can't ignore this thing that we've all just been living through. In terms of the pandemic, it became really clear in comparing outcomes across countries, in places that had leaders that were able to mobilize pro-social values of being willing to sacrifice for a common good, did much better than other places. Now that's a data point. It's well known. People have written about it already. But the normal reply to that is kind of throwing our hands up in the air and saying, oh, well, isn't it too bad we all can't be Denmark because they seem to have it figured out. But in making those kinds of observations, it's not to say that some societies have good values and some societies have bad values. And, it's just, you're fated to live in one of those based on accident of birth. We all societies and all cultures contain a multitude of values. In our own country, we often think of the dominant narrative being a yourselves up by a bootstrap, rugged individualism. That's absolutely part of what is going on. But we also have barn raising narratives, right? Or let's throw a show and raise the money together. So we have narratives, and it's really important. Political leadership and grassroots conversations are really important to find, to mobilize the values that can help us collectively combat medical issues. And along those lines, let me just mention one other example that's very relevant today to our backyard. The debate over vaccines and vaccine skepticism or anti-vaccine activists, or there's a multitude of terms to try and encompass the spectrum of people who are hesitant to get vaccines. That debate isn't about data. It's not about what the science is telling us. It's not about like producing more studies to convince the other side. That's a debate about values, a debate about ideologies. And if we try and understand the other side of those debates, we can sometimes find a common ground. They're not also, a skepticism of big pharma and their interest in selling vaccines that get injected into our body, that's not irrational to be skeptical of these big systems like that, or anti-authoritarianism. At the same time, we can probably find common values. We all want the best for our children. We would all want for them to be healthy and well, to go back to our initial question. So I think finding a common ground on values can address a lot of the crucial issues that are facing us today. And I'll just give one example. And sorry, this is the problem with academics, is we could just talk forever about the stuff that we've been looking at lately. But the Prime Minister of Denmark, Mette Frederiksen, she resurrected a somewhat archaic Danish term in the early days of the pandemic, samfundsend. And it meant a community coming together to sacrifice for a greater good. It's sort of fallen out of it, but she said, this is a fundamental core Danish value. And this is the reason we have to mask and social distance and close schools down. And it resonated with me. And that kind of using the narrative of values can move the needle in public health.
Dr. Dixon, did you have any thoughts and comments on that?
Yes, I want to echo what he says about values. I think that when we have common ground and we can come to common ground, then that creates an opportunity for the common good for all. And I think that when we talk about what I was going to say earlier, we were talking about health equity, health equality, and improving access for all, making sure that there is a common ground. We're human beings, we're not perfect beings, and we're all individuals and we're different, and we will have differences of opinions, but looking at what is best for the greater good. And that does go back to what your values are and how you put the common good and what is in the best interest of all at the forefront. If we think about this pandemic, and not just the pandemic, but health disparities, equal access to care, and recognizing that it's like you can throw up a ball of rocks, a bag of rocks, and they fall out and everyone has the opportunity to grab some. But then understanding that everyone does not have the same capabilities. And so when you understand that and meeting people where they are, that's the theme that I've used throughout this year and even before, meet people where they are. everyone may have needs, but how you meet those needs may be different. And so when you understand that, embrace that, have the conversation so that you gain an appreciation and value what those concerns are, then that's how we can move the pendulum in the direction of improving healthcare for all, helping improve access of care as well.
We have a question actually on that that's come in from the audience, which is, yes, but how do you talk about the common good without it seeming socialistic or as a form of socialism? You thought about that?
Let me clarify over that not being referred to as socialism.
I missed that part.
Go ahead, Kimmy.
Or with the comments about the common good not being referred to as socialism by the people hearing it.
I think that people will automatically want to say, well, that is socialism. But I always like to stick with the facts. As Dr. Fischer was saying, we can talk about the science, and the science does help support decisions. But when you think about the facts, if we talk about health disparities, and you know that there's certain populations and certain communities that are disproportionately impacted, that's not a theory, that's not a hypothesis, it's a fact. And if we just look at the facts and maintain the facts, and because of the facts, then ask the question, now what are we going to do? Because we know these facts. When you know that African Americans are disproportionately dying at a higher rate, not only from as a result of the COVID-19 virus, but from heart disease, from hypertension. You know that as a fact. And then what are some things that are contributing to that? And so you start with the fact and then go in reverse to say, okay, now why is this happening? Is it behavioral? That could be some of it. Is it socioeconomic? That could be some of it. Is it environment? That could be some of it. Is it systemic? Is it genetic? So you look at all of those. And so that helps to not get it bogged down into a socialism format and platform. But it's very easy to be pulled in that direction. But again, if our goal and our outcome is to improve and to create better outcomes, then we stick with the facts and actions as to how we can address that so that it doesn't become a socialism issue.
That's a great answer, sort of going down to the...
It wouldn't be...
That's a great answer, going down to the specifics that way. And a great question too, right? This is such a charged rhetorical environment in which we're having these conversations. And it's easy to throw those, lob those pejoratives like that, socialism. So I would agree. Looking at the facts, also talking about specific kinds of outcomes that we would like. Okay, we don't have to like all hold hands and sing Kumbaya, but like what direction would we like infant and maternal mortality rates to go in 10 years? And then, what's the best direction to get there? Another sort of, in real conversation sort of strategies that I have used before that I think can be effective are acknowledging the shortcomings of socialized medical systems. They produce lots of better outcomes. If we wanted just like longevity to be better, we would adopt Sweden's healthcare system. But you can also talk about, lack of choice, not as innovative, long waits. I mean, critiques are not all wrong. And probably the best kind of model is some kind of hybrid. This does, and I have to say it now, and I almost hesitate to, because among my left-leaning academic colleagues, I'm always accused of being the apologist for the market or being the most market-friendly. But it's also, we got to think about the profit motive in healthcare. And I know that automatically also starts sounding socialist. But the closing of hospitals, for example, as consolidation takes place and people are trying to squeeze ever greater efficiencies out, we got to find some way to talk about the common good, because these institutions, public health care and rural hospitals, or hospitals that serve populations, these are public good things that a country as wealthy as ours should have, I think. And so, I don't know. I don't know exactly where I'm going for that, but I did. There's a great article, I think, in the current issue of the New Yorker about hospital closing. Is making money about these consolidations. And it does raise the question of, like, when push comes to shove, you know, do we want to incentivize doctors to see as many patients as humanly possible, or would we like to incentivize them to have some kind of human connection with their patients and be able to uncover underlying causes? And the closing of hospitals. Anyway, I'll stop.
Well, no, it's a good. I think it gets to the point of these difficult conversations and why they're difficult. And so you started and you qualified before you made that statement about the pushback you were going to receive. And I think, like, there is this kind of hesitancy to go there, if you will. And if we don't go there, how are we going to make it better? And I think that do you prefer Farmer-Dixon or Dr. Dixon? I want to make sure I'm addressing you appropriately.
Either one, either one. I answer to both.
Okay.
For simplicity, is fine.
Okay. Well, Dr. Dixon, so you're a dentist, right? And so you
Yes.
touched on this with regards to addressing disparities in healthcare. So in your opinion, how do we create an action plan for addressing these disparities and some of the things that Professor Fischer also mentioned, and also would love to hear a little bit more from your perspective as a dentist, because I know that dental health is a significant concern, and there's significant deterioration. It's a source of pain and many other infections that stem from a deterioration of dental health that we're seeing across the state and the country, and particularly in rural areas. I know I asked you 2 in 1.
Well, I think that the way that we begin to address this is that we have to meet the people where they are. And I think I said that earlier. And by meeting communities, and so you can't just decide, oh, there's not healthcare in this area, let's just go and let's set up the healthcare. Because just because you're open doesn't mean that the people will come. So you have to first establish a level of trust in the community. And just because, I'll use myself for example, just because I am a doctor, I'm a dentist, and I go in a community, I may be trustworthy, but that doesn't mean that I'm going to get the trust. Right. And I do that by building relationships within the communities. And so I think we have to start there. And by building those relationships, you develop a level of trust, but it starts with, in building those relationships, educating the people on what is good health, what is health and wellness. And then not just giving them the education, but then understanding that community. And that's where cultural competence comes in, so that you understand what are the values and beliefs of this community. There's some, and because I'm a dentist, there in some cultures, it is that you use natural medicines. And so I'm not going to go in talking about giving prescriptions for antibiotics, but I would need to understand and be able to educate them on natural medicines that they can use. And in some other cultures, it's that my parents lost their teeth when they were young, my grandparents, and they think that's a natural progression. Right. And so educating them on that is not necessarily the case. And so once you have educated, then how do you help them identify resources and avenues so that they can, people want to be healthy. Sometimes it's a financial thing. Sometimes it's a fear factor. There's several factors that come into play. And when it is a financial, being able to help to identify resources. And that's where it's so it's a multi-layer problem and challenge. But I think what I want to see us doing, the one thing that I think I have seen with the pandemic is that communities were creative in how you met the people where they were to encourage them to get tested, when this first started, and now with the vaccine. Every day we see, even on the news today, there's an outside concert that's going to be here in Nashville, and they're going to be giving vaccines at the concert. In some states, they're offering lotteries to get people to get the vaccine. So they're being creative, and so the creativity that has been that has evolved around healthcare and improving healthcare and improving access is something, a momentum that I hope that we will keep and can be very useful in addressing health disparities and how we change the paradigm and start to improve healthcare, particularly in rural areas and in communities of color and in those underserved areas that are disproportionately affected.
That's a brilliant answer. Very, very insightful. And one of the things that really stuck out for me is also that about talking about trust and your point that you can be a trustworthy person, but that doesn't necessarily mean that you have the trust. And I think that that gets to some of your work, right, Dr. Fischer? And as
absolutely, I couldn't have said it better. I like that trust. It's you know, it's hard earned and easily lost, and I think the point that Dr. Farmer-Dixon was making is absolutely crucial. We a lot of times, especially in healthcare, we assume that trustworthy people will be trusted.
Right.
And it has to be built up over time, which is not easy. It involves give and take. You have to give trust in order to receive trust. And that's not easy for people often in medical professions to be able to do. And it speaks to what you were saying. I keep pointing over here because you're on that side of the screen to me, Dr. Farmer-Dixon. And that requires some humility as well, right? To be able to listen to people and trust them, you know, sort of understand where they're coming from and try and trust them. So I think trust is absolutely crucial. History matters in trust.
Mm.
And a lot of times, you know, there's this whole field of medical humanities, and most of the time, people in medicine say, "Oh, that's just." Actually, histories really matter. It matter. The syphilis trials in Tuskegee matter even today when we're rolling out public health campaigns with communities. These memories live on in so many ways. To use an international example, you know, the CIA, part of their hunt for Osama bin Laden, they were going around in a Hep C vaccine campaign in rural Pakistan to collect, surreptitiously collecting DNA swabs from people. That has negatively affected the ability to roll out COVID vaccines in these same areas of rural Pakistan. And again, that's not, you know, it's rational from the point of view of these Pakistanis in some way. You know, we're bringing in this medicine from abroad, but it also underlines Dr. Farmer-Dixon's point is you can't just show up in a white coat and say, trust me. It's like, or say, hey, last time, yeah, it was a ruse, but this time it's for real, so please take the shot. It's too late. You know, the house is already burning down. You've got to build up the trust far in advance. And sorry to get on my soapbox, and this is the last thing, but Anne, that points out to something that's been in the conversation today is that all of this, what our healthcare system needs, public health, is sustained investment in stuff that's not sexy at all. Health outposts, it's having dental clinics available to people, it's having, you know, it's all of this stuff that really, that politicians very often find it easy to write off of a budget line when things are tight, because it's not a problem that's immediate today, tomorrow. But this is the kind of investment we need to make to have a more equitable system.
Absolutely. So we've got a couple of questions in the chat box, if you're all right with me reading some of them. All right, so how can we encourage public and private healthcare executives to voice truth to power and enable equality and access when they are dependent financially? And how should those leaders frame these issues when equality of access and often the financial stability of public institution are not shared values? I'm going to post it in the chat box too, so everyone can see it.
Okay. I think that it's that some people will say it's difficult to separate healthcare from politics, but it has to. When you're talking about healthcare, it doesn't matter if you're Republican or Democrat, or if you're an independent, if you are left wing or right wing, in terms of if you get cancer or if you have a heart attack. Uh, Though they're not politically related. And so I think that we as citizens, our legislative people, our legislators represent us. So I think that it is incumbent upon us to use our voices and use our power to remind them of the duty that they have as a servant leader, and inform them. Our voices are powers. And so just as we're saying that we have to educate the communities, I think that it's important for us to help educate our legislators on, again, the facts and the impact of their decisions and what they will have in our communities, so that we keep in mind that we voted them in and they can be voted out when they are putting politics in front of healthcare.
Yeah, and I would agree with that. That's as tough, that's the $1 million question in the millions of conversation that we're having, because that's the reality that we live in, and we've got to figure out how to do it. It often sometimes helps, again, just sort of thinking like, kind of 101 or lobbying kinds of things of humanizing the impact of this, like telling particular stories of their individuals. We also, though, in a longer term, we've got to rethink compensation system that pays for healthcare. And yeah, public good hospitals need getting more from Medicare and Medicaid to subsidize the rest of their operations for the moment or while we're in that system. But we also need to envision a different system that is financing all of this stuff.
Say more though. Can you tell us a little bit more? Because I know that you've reimagined some of this. So can you give us a little bit of an idea about what you could see working in the US context?
I don't. You give me too much credit. I've thought about it, but I don't have any answers. The pragmatics of it is, in the U.S., we're going to have to, if we can decide that we want to expand access to healthcare, and that's the whole thing, is how do you frame that in a way that is palatable to a lot of people? There's lots of great data. Living in places with unequal access to healthcare makes everybody's health worse. Not just the people who don't have access. The people who have access's health is worse. But we can make that self-interested kind of argument that this is actually good for everybody. To be frank, I think that it's a slippery slope when we start making those self-interested arguments. I think a more powerful argument is it's the right thing to do. And I don't. But pragmatically, it's going to have to be some kind of hybrid model. We're not going to get rid of private insurance, I don't think, short term. People, and so I think we're going to have to look for some kind of hybrid model. But we've got to decouple health insurance from full-time employment, or at least have a supplement to add on to that.
Well, Dr. Farmer-Dixon, I wanted to ask you if you wanted to comment on that, then I had another question for you.
Yeah, I think when we mentioned the compensation rate, and I think, when we think about healthcare in general, it is costly, and typically it is the poorer and the underserved that are the least healthy people. And so how we look at the compensation model and improve that. But, and again, using dentistry, people will not have dental health care because it's not affordable. And so creating, as he said, hybrid models, because I don't see private insurance going away, but giving affordable options and alternatives, so that when we're talking about going back to health and well-being, and that being the whole body, the mouth, the physical body, and your mind, being able to afford and all of those aspects, so that you're not just talking about it.
And on that note, you talked about putting politics in front of health. I mean, people putting politics in front of healthcare and that being part of the problem. How do you think we depoliticize the conversation around healthcare? How do you think we encourage our two-party system that includes entrepreneurial politicians to do the right thing?
It's something that Dr. Fischer mentioned, and values. And part of that comes from a person's internal values. And it's just amazing to me. And it's kind of disheartening in some instances to see the politics being put before healthcare. And I think we have those conversations. And you know, I always believe in just being kind of transparent and again, pointing out how politics is negatively impacting when decisions are made on politics versus what is in the best interest of healthcare. I think it's just as it has gradually gone into that. I think, you know, being diligent and vigilant about trying to transform that and pull the politics out and using individuals' platforms and having individuals to, that's not everyone that's in politics. So the greater good of those that are not, letting their voices be heard even more and louder, and those in the community voicing louder to really push that agenda.
Yes. Before we go into breakout sessions, Dr. Fischer, did you want to say anything else on that?
Yeah, I think that at a lofty level, I think we have to redefine how freedom gets deployed as a word and a concept in these conversations. And we can understand, you know, freedom to live a long life or freedom of your choices not to negatively impact me, or we can understand freedom as a radical individualism. And I think we got to find a common ground on that to deal with some of
What do we mean when we say freedom? Yeah, what does
Yeah.
freedom mean?
Yeah.
Wow. Well, thank you. Well, as you can see in the chat box, there are a lot of questions. You sparked a lot of thought. So I'm sure that people are going to be hoping that you're in their breakout room. For the questions that we didn't get to, feel free to email those to us and we'll try to get those answered if they're not answered in the breakout session. So with that, Cameron, can you take us into our breakout rooms?
Of course.
Thank you.
Breakout rooms are opening up right now. All right. Hello, everyone. Looks like we're going to be filtering back in from our breakout sessions right now. So I just want to take some time and highlight some of the conversations that we had in our breakout sessions. I know that the one that I was in, I heard a lot of great insights from some of our attendees and some of our partners. And so I wanted to give some space to share anything that you might have discussed, anything that you might have learned, either during the event or during the breakout, sort of like an open floor.
Well, I will share. I think one of the things that came from ours really was something that stuck with me, was something that Randall said, that will stay with me for a while. And that is that one of the reasons we have a trust deficit are that people are suspicious of one acting in their self-interest and acting out of self-interest because they are acting out of self-interest. So they assume that the other person is too. So until we can address that, we're going to have a trust deficit. And so we have to figure out, and Randall, maybe you want to chime in here. I don't want to put you on the spot, but we got to figure out how we address that. And I feel like that's a little bit too as to what Dr. Dixon and Dr. Fischer were also saying.
Yeah, I don't mind chiming in. And I think the answer to that is we have to talk to each other. And when we talk to each other and we learn that the other one is actually serious and not necessarily just in their own self-interest, then the trust factor grows. But it has to, I think one of the doctors said, trust has to be built. It's not automatic. And that requires talking to each other.
Sean,
Go
Go
ahead,
ahead.
Jackie. No, you go, Jackie.
Sean Ahmed in our group talked about a study she read that at some point somebody did a study saying they compared what patients paid based on what they were dealt with at the beginning of their connection to a physical office for medical care. And when they first were asked about the insurance card and all those kinds of things, they found that 65 to 70% of the bills were not being paid easily. And yet when they flipped it around and said to the patients at the beginning, we're here to take care of you. Let me get all your information. Let me see what you're here to do today to find out. They started that way. They found that dramatically increased the number of people who actually paid their bill. And maybe that has something to do with the trust level.
Absolutely, and that's what I was going to say, the same thing, actually. It's really important how we frame these things. And if we frame them that we really want to improve someone's health, and it's not just an economic transaction, it could make a big difference. You know, I would get rid of, if this were possible, if I could wave a magic wand, I go back, the 17th century British philosopher John Ruskin once said that a profession is what is worth dying for. That a priest would rather die than his flock go to hell. That a physician would rather die than to have a patient lost. And I think if we could operationalize that, like I would get rid of all malpractice insurance. If my doctor would just swear to me, I would rather whatever happens to you happen to me. And if I believed them, you know, it would be starting from that point of trust. Sorry, that was a little off.
Courtney, do you want to summarize what we talked about at all?
Well, I was going to actually add to this conversation because I think the way we ended our conversation was very interesting about healthcare as a privilege versus a right. And how do you speak across? So for people who believe healthcare is a privilege versus people who think healthcare is a right. And as you see disparities continue to become, you know, more spread, and especially in communities that are poor or communities of color or communities that maybe don't have the privilege of healthcare, how do you convince the other side of privilege versus right? So I would love to pose that question here too. There was some really interesting conversation going on about it that I thought was fascinating.
Well, I'll say that I think I'm very much aware that with all the people that I know who start with TennCare, with Medicaid, overwhelmingly, the messages all go to the emergency room, and that's where they get care. So we are taking the poorest people and we are putting them into the most expensive healthcare management system they could be in. And that doesn't help them particularly. It doesn't get ongoing care, and it certainly raises the costs. So when we look at that function of going to the emergency room as the primary vehicle, we need not to eliminate emergency rooms, obviously, but to change that behavior set, because it would change a lot. And maybe that's the reason the privilege right thing has such a difficult way to talk about it.
One of the things we said that kind of came out was that folks who don't get health care don't feel like they deserve it. And you know, people are going to the emergency room because it's an emergency at that point. You know, they're not getting basic health care and they aren't demanding it. And that's, you know, and the people who do get health care are using it to the fullest extent possible. And there's such a disconnect that when I talk to folks who are sick and poor, there's no conversation about why is it this way and this is unfair. I don't ever hear that from folks. It just isn't in the air at all for them. They just accept that that's their lives and that's how they're going to go. You know, so we're trying to put our values onto something that I'm not sure that they have sometimes.
That's
think
a
how to
really
convince them of
powerful
that.
point.
I think the experience I have with poor people is they don't know what to do. They don't know how to find a doctor. They don't know how to find a nurse. They're so afraid of the first bill being so high that they don't deal with it. And it's not that they don't want to or don't think they have a desire to, they're just afraid of spending the money. And then it gets so bad that somebody ends up taking them to an emergency room. It's like flipped from what we want to do in delivering of healthcare.
It also does stem from, oh, go for it.
I'm sorry. Or even knowing where to go and what to do. I have a friend who I've had to talk into going to the doctor and how to process getting to a doctor and how to, it's just like my daughter-in-law used to teach second or third generation families who had lost the ability to cook at home because they lived in food deserts. No one had shown them how. No one had taught them how to do that. And it's the same thing with the habit of going to the doctor, the habit of seeing a dentist or an eye doctor. It's not part of what they know. And it is a frightening system, and the systems have not been their friends. And so going into the system is a frightening thing, which leads us back to the trust piece. But I've been in the position of not having insurance and making do when our children were very little. And when you get in the habit of making do, you are in the habit of making do.
Stemming from a point that Dr. Farmer-Dixon had made previously, it also just comes to the conversation of culture and what treatment is. Coming from a background of being Kurdish, a lot of times, like, as many people have said, dental care wasn't a common thing. And so going in constantly to get care, it was either terrifying because your first round, and like this is coming from a story from my mom, was having to get so much fixed so quickly because you never prioritized it to begin with. And that's very intimidating to go to other doctors about. But on the alternative, it also just comes at like, and this is touching from a point Jackie talked about in our breakout room, is so many people go for the most expensive option of going straight to the emergency room. And yes, it might not be like, in many cases, it's an emergency, that's what they need. But also in many cases, that might not be the case. It might just be something that they don't know isn't an emergency. It's just something that they do not understand what it is. And that's the first option you hear. Because whenever you pick up the phone for a healthcare provider, your first thing, and as much as it's a liability, it's if it's emergency, call 911. And for someone who doesn't understand that, like, is this something severe or is it something I just haven't seen before? That's their immediate reaction is let's go straight there. And that puts them into this rabbit hole of, oh, if I get healthcare or if I go get care, there's so much more I have to pay for all of a sudden.
You know, the other side of that is, you know, we could design our health system to acknowledge that fact. Like Vanderbilt used to have a system that they don't anymore in the emergency room, where they would have nurse practitioners. So when someone showed up with something that wasn't a real emergency, the nurse practitioner could just deal with that and bill them, you know, as a primary care visit. I don't know why they stopped doing that. Maybe they're doing it again. But you know, if it's probably easier to change our health system in some ways than that culture, you know. But but we just demand that people, you know, fit into this health system that we've created. So
I think one of the things that I've seen is that I think many times there's so many assumptions that we make and that individuals in the healthcare system make when it comes to individuals and communities that are very much disproportionate. And those assumptions, I think many times is what's really holding us back in terms of how we really can provide the best, quality healthcare for those individuals that are disproportionately affected by many of the disparities. One of the things that I'll keep saying it, Dr. Farmer-Dixon's probably gonna get tired of me saying it, but she mentioned in our breakout, is meeting people where they're at. And I think that that's something that we have somewhat failed, at least that's what I've seen, is that we're not meeting people where we're at, and meeting people where they're at You know, as we all know, before we walked, we had to crawl. There's a progression of steps that has to be taken. And many times when poor people enter the ER, yes, that to them may be an emergency, but are we even at that point of access meeting those individuals where they're at? And many times I would probably argue we're not, because meeting them where they're at means pulling back those layers, going under those underlying issues to see, you know, why they chose to help to come to the ER, or, you know, just many other factors and things like that. But I think we just get stuck at the assumptions of what we think individuals are or the environments they live in, and we're not willing to meet them truly where they're at and go further to those underlying issues.
I am wondering about this assumption that it's a choice to go in a behavioral thing rather than a structural issue. In the community that I live in, our primary care system doesn't have capacity to do normal primary care functions, and that's what's pushing people to ER departments, that we just do not have the capacity to have normal primary care functions because everyone is now trying to go to the doctor again with things that, you know, are a range of severity of issues. And it's specifically the lack of availability that's pushing them there, not cost, not behavior, lack of other options.
Or lack of insurance.
No. I mean, these are people that have insurance through the state, public option. And these are people that have private options. And there are simply not enough appointments to meet the demand for primary care. So that pushes it to where it is 10 times more expensive. And then we have people cutting the budget further for primary care, thinking that that will save the state money, when in fact it increases medical expenditures, which often go to the taxpayer, by about 10 times when preventative medicine turns to emergency medicine. So it's financially irresponsible, but because those costs are borne by different parties and that cost isn't transparent, sometimes the same medical institution will externalize the costs to a different department because there are different funding streams and they aren't reconciling them internally. So I know in my community, a large driving force for people choosing, or no, not choosing, for people being pushed to emergency medicine is the lack of availability of primary care, largely due to the rate of reimbursement for providers and institutions from Medicare and Medicaid.
What size community do you live in?
Is this a rural community or an urban community?
I live in Madison, Wisconsin, and I've seen this both when I was working at a rural hospital about 45 minutes south and a nursing home that was in rural communities and we're working there. And now I'm working at a clinic in Madison itself. And in both cases, we're dealing with the infrastructure being gutted for basic provision of either ambulatory clinical care or rural community hospitals. Yeah, so it's hitting both places, and the reasons aren't transparent because we aren't having the legislators held accountable for their decisions in a public way from nonpartisan policy officials. And I think that's a really important place to start for transparency.
Wow, so a lot of great feedback, a lot of great insights. I know we can all continue to go the rest of the evening discussing these issues, but I do want to be mindful of everyone's time. And so with that, I will go ahead and close out this amazing conversation that we had this evening. I want to take a moment to specifically thank Dr. Fischer and Dr. Farmer-Dixon for their insight, their expertise. What an incredible conversation. Thank you for piquing our interest. Thank you for shedding light on issues that are affecting so many Americans today. Another special thank you to our partner, Core 54. We wouldn't have been able to have done this without you. It is partnerships like yourself that we look forward to really help have conversations, but really move beyond conversation and into action. So thank you to our partners at Core 54 for all you do. And then finally, to our participants in our audience, thank you. I have to say, this has probably been one of the most engaging conversations I have been part of since joining Millions. I really appreciated the breakout sessions and this session in particular to hear your insights and thoughts on that. So thank you all for participating, for listening, and for sharing your thoughts with us this evening. Finally, if you have not done so, please take a moment to take our pledge to listen, share it with your networks, and sign up to be a listening facilitator. We have put those information in the chat box for you all. And remember to follow us on social media and the platforms, and also follow our partner, Core 54. Once again, thank you all again. Have a great evening, and we are looking forward to our next conversation with you all. Take care. Bye-bye.